My name's Craig, and I was diagnosed with PCD when I was 7 years old, but I was actually diagnosed with situs inversus as a baby, because when I was born I had some chest infections, and then I had x-rays, and obviously that's how situs inversus was diagnosed.
Well, as a child, I was always getting jokes about how many cigarettes I smoked, because I'd always got a really fruity smoker's cough. When I was about 12, I had a chest x-ray, which turned out to be the wrong way round, and at that point I was told I had Cartagena syndrome, and I wasn't told any more about that. So I just grew up. I had chest infections, ear infections, sinus infections, and then when I grew up, got married, had 2 children normally, perfectly normal pregnancies, and then only when I was 34 did I have a referral to the Brompton Hospital in London, and they told me all about PCD. They also told me that I had to start a whole new treatment regime, which was taking really strong antibiotics, exercise, which is what this is about, to try and get breathless, to move all the phlegm, taking inhalers to reduce the inflammation and inhalers to open the airways, and physio, which at that point is tipping up with your head down, doing special breathing to clear the chest. So that was a bit of a shock. It took me a long time to get really into that. And then more recently I've learned a different sort of physio, which is called autogenic drainage. That's really handy if you've got sinusitis, because if you've got sinusitis you don't want to put your head down. So you can sit up and do autogenic drainage. It's a breathing technique, and it brings up the phlegm ready to cough. So if you want to know about that, ask your physiotherapist. Autogenic drainage.
My name's Dr. Rob Wilson. I'm a chest physician at the Royal Brompton Hospital in London, where I'm also clinical director. I run the infection firm here at Brompton, and I see all forms of different lung infections. Some of my patients have primary ciliary dyskinesia, which is a hereditary condition which can cause bronchiectasis, which is damage to the airways of the lung, which makes patients prone to catching lung infections. I only see adult patients, and they're usually sent to me because either they've got a chronic infection or they keep getting recurrent acute infections. And the first thing that I do is take a history, and there are some clues in that history that a patient might have primary ciliary dyskinesia. So patients with this condition tend to have problems from birth. They're born with an abnormality, and therefore that abnormality kicks in straight away. And if the patient hasn't had anything wrong with them at all for 5 or 6 years until they're a young child, then it's probably not primary ciliary dyskinesia. Also, this condition affects all parts of the respiratory tract where cilia are. So they often have also nose symptoms or problems with their ears. And again, that is a clue that sends you in that direction. Having taken the history, I go on to examine the patient and then order some investigations. And some investigations are specific for people that I think might have a ciliary problem. We get them to breathe out through their nose into a machine, and patients with primary ciliary dyskinesia have low nasal nitric oxide. We use that as a screening test, because if it's abnormal, and if I suspect the diagnosis, we take a brushing from people's noses. And this picks up cells on the brush, which we look at under the microscope, and look to see whether the cilia are beating normally. And we also have machines which measure how fast the cilia are beating, and also the pattern of the ciliary beating. If this confirms the diagnosis of primary ciliary dyskinesia, we go on to assess the structure of the lung with a test called a CT scan, and also breathing tests to look at the function of the lung. We also measure people's exercise tolerance and have a look at their phlegm, if they're producing any, to see if they've got any infection present. And then with all this information, taking together the history, the examination, the results of the investigations, we construct a management plan to try to give the patient advice on how they can stay well, and also to manage how to manage their condition if they have problems.